We usually suggest that for, so this is in the right gluteal region, so for extremity sites, slowly progressive swelling may be observed, but anything that keeps growing and I think more than say 5 centimeters, we would like to definitely assess and rule out the malignancy, and if it's there, the grade. So since there is a sudden change in the rate of growth, I would definitely like to assess this now.
Okay. So one simple message here is that mesenchymal tumors are a mixed bag of lesions where spectrum is right from benign, very slowly growing till very aggressive malignant tumors, and history can clinch diagnosis in many of these patients. So this patient had ultrasound before reaching me, and the size was pretty small, less than 2 centimeter. Now, again requesting you to take it further. Now, what is your thought? As you said, if it's about 5 centimeter, then we need to be careful and we need to assess further. Size is pretty small.
Yes, but again, so there is this peripheral vascularity. So this and the history that it is suddenly started growing faster, I would like to evaluate this further.
Okay. I'll go to Dr. Jadhav. Dr. Jadhav, are you happy with the ultrasound, or you would like to assess it with any other better imaging modality?
Yeah, so
Or you feel that it's a very small swelling, slowly growing, we can just manage with ultrasound?
no, ultrasound, it's showing though the swelling is small, the important finding that is picked up is that it's a vascular swelling. So obviously I would like to evaluate further, preferably with MRI, because that will not only assess the size, but it will also tell us whether there are any heterogeneous components in the swelling, whether there is any element of necrosis in the swelling. It will also give us idea about its involvement with certain deeper structures, which an ultrasound may not be able to pick up. So it will give us a lot of information about the actual extent of the swelling, as well as it will, give us some clue about the true nature of the swelling.
Okay.
If there is some necrosis of some heterogeneous components, then it's likely to be more in favor of a malignancy, that to a high grade one.
Thank you. Let me go to Dr. Dev Malla. Dr. Dev Malla, you as a pathologist, you are looking at histopathology of these varied tumors, and we know that sarcomas, because it's a mixed bag, it's pretty difficult at times to diagnose them. Such a small swelling, will you be worried? Will you be really looking for an additional MRI, or you can manage with the same? So what will be your advice for the imaging before a biopsy is done?
Thank you, sir. Just first, I want to see the tumor compositions. It is the homogeneous, or it has some the other area which is heterogeneous looking, internal hemorrhage or necrotic part is there or not.
Okay.
In periphery of the lesion, I want to be focused that is this infiltrating, and it is on the just the fascial plane, or it is infiltrating the muscles. That's all are important.
Okay.
As well as the clinical examination also, that's the skin, the nature of the skin, it is ulcerating or not. Just one thing I just want to make a comment, the no role of FNAC here, because we used to get the lots of people will come with the soft tissue swelling and FNAC report. And because FNAC has the no role in the diagnosis of the soft tissue sarcoma, either benign or malignant, it can help in the recurrence. If there is a known already established soft tissue sarcoma, and the recurrence lesion come, then FNAC definitely can give some idea.
Sure.
But for the primary diagnosis, we should be rely on the core biopsy, followed by the histopathology and molecular and so, but the no role of FNAC.
Sure. So again, based upon this ultrasound, this biopsy was done at an outside institute, and it showed spindle cell lesion, query low to intermediate grade. So if a surgeon or a medical oncologist or a radiation oncologist get such a report, what should we infer with this? Is this good to go with the final treatment, or you would like to look at it in a slightly different way? Can we get more information from this?
First thing, the report is not the adequate, because the tissue diagnosis should be there. The only grade is not enough, because there are lots of tumors which are by look wise is very low grade, but actually they are the malignant. And it should be there what is the cell of origin and what is the degree of differentiation. So spindle cells can be the glioma, sarcoma, can be the synovial sarcoma, it can be the rhabdomyosarcoma also. So the lots of things can happen, and I am sure these on the medical oncology point of view and surgical point of view, the management is totally different. It can be a simple fibromatosis also.
Exactly.
So this diagnosis is not enough. We require the immunohistochemistry full evaluations and then a proper diagnosis where the histogenesis should be mentioned. Ki synovial, it is the liposarcoma spindle cell, it is a leiomyosarcoma, it is rhabdomyosarcoma, whatever.
Correct.
And then the management part will definitely come.
Okay. So we don't have surgeon on the panel at present. Anybody from the audience surgical side, if okay. So the surgical question which arises here is that you have a slowly growing swelling. Biopsy has come as intermediate to low grade. Do you really want to do something ahead, or you can just wait and watch, or maybe excise this on this basis? So that was the surgical question I was trying to address, but I think I'll address it myself that, you know, we have seen multiple times that even very small swellings can be high-grade sarcomas. As the Devmala rightly said, that slowly growing swellings which can be desmoids, and dealing desmoids surgically is a complete different ball game altogether. Nowadays, actually, we hardly operate any fibromatosis. We don't operate them, and medical management or additionally with the help of HIFU or cryo is the main management for fibromatosis, because the local recurrence rates are as high as 80% in desmoid tumors, because they are infiltrative, and if you really want to have a cure with surgery, your margins have to be like 8 to 10 centimeters, because you, even on the best of the imaging, so the MRI, you can't see how much of the muscle fibers are really involved. So, you know, even at this stage, even though you have everything putting together like a slow growing swelling, which is low to intermediate grade, we should not jump gun. We need to assess it carefully. Two things which are lacking here is the appropriate imaging in terms of MRI, as you rightly said, and as Devmala pointed out that this report is not adequate, we need to look further. So we did MRI, and this was the swelling, a small swelling in the gluteal region, which was taking the contrast, dark in T1, like any other swelling. This was the size, which was about 2.5 centimeters into 2 centimeters. And histopathology, when we reviewed it, it actually turned out to be a high-grade pleomorphic sarcoma. So now the question starts that even the small swelling, even which was growing slowly, sarcomas can behave in a different way. And as we discussed that, we need to really reassess them properly. Now, let me ask you, now this is the scenario just changed slightly from what we were looking at. Do you want to do any further staging here, or you feel that small lesions are unlikely to be metastatic and we can just let it?
Any high grade? For any high grade, I would like to go for the staging, sir. Sure. And previous question, I actually have a doubt. Like, how is it possible to to label it as low or intermediate grade? Because grading we will do as per FNC LCC, so it has to be either low or intermediate. Intermediate will behave more like a high grade thing. So I just wanted to ask, sir.
What is your question, please?
His question is that when somebody has reported it low to intermediate grade, it should not be like that. It should be either like intermediate grade tumor or a low grade tumor. So what is your comment on that?
Yeah, first thing I should say ki before mentioning any FNLCC grading system, one should be the histogenesis of diagnosis. I am just sharing my experience. Just 2 days back, I have a patient of the 45 years old with a mass in the buccal, in the fat plane of the masseter muscles, and it come out as a spindle cell sclerosing rhabdomyosarcoma. So see, it is a very bland looking tumor. Only the spindle cells which are no mitosis actually, or very rare mitosis, which is just infiltrating the muscle fibers. One can miss it like a fibromatosis. One can miss it like a nodular fasciitis, non-tumor also. So before taking this FNLCC grading system, the report is not complete, basically I want to say. Before telling something about the grading inappropriate or correct, the diagnosis is not the adequate here. So first you have to mention what tumor it is. There are lots of spindle cell tumor, starting from the leiomyosarcoma, liposarcoma, synovial sarcoma, and suppose the synovial sarcoma, it's a hypercellular spindle cell tumor. You not get any atypia. Only the undifferentiated pleomorphic sarcoma, you can get the definite degree of atypia.
Yeah.
So
I think what we get information here again is, as I was mentioning, that diagnosis of sarcomas is not simple. It is pretty difficult histopathologically and as well as on imaging as well. We can't really characterize the tumor so well that we can reach to the histopathological diagnosis, and management also differs. Hence, we need to train more and more people in these subspecialties. I know these are rare tumors, and I think ICON is a great platform where we can initiate something very specific to training of these subspecialties, whether it is pathology or radiology, and we can do something about sarcomas. Okay, so I was talking about how to stage them. So I think as you rightly said, that any high-grade sarcoma needs to be staged, and as per the NCCN guidelines or ESMO guidelines, or what we have in India as IMSOS, and other guidelines as well, these tumors most commonly metastasize to lungs, so we need to do a CT scan of the chest. We don't have to do a contrast enhanced CT. We can do a plain CT scan of the chest with thin slices. A 3 millimeter slice is preferable for these lesions, and there are some soft tissue sarcomas which have higher propensity to go to lymph nodes, especially angiosarcomas, rhabdomyosarcomas, synovial sarcomas, clear cell sarcomas. These kind of sarcomas we must examine as well as do ultrasonography of the nodal basin, which is the draining, the first echelon. We must do that. And if you have any regional metastasis, whether you see in terms of skip lesions, so about 2 to 3% of soft tissue sarcomas can have skip in the same compartment in the same muscle as well. So if you have these skip lesions and if you have nodal metastasis, then I think it requires a further staging in terms of CT TAP, where we really need to see that how do we go ahead. So now, I'm asking you a surgical question now, and what, as an MDT, what will you suggest? It's a small lesion. What will be the final management for this patient? Obviously, we all know that sarcomas needs to be excised. So excision was done. This is the final histopathology of the lesion. Two main questions which stand here in this case and which are very simple to understand is that with such a small lesion, which is about a couple of centimeters in size, which is excised really well, where the closest margin is about another 2 centimeters, do you really need to add radiotherapy?
So as per the guidelines, what we suggest is that we avoid adjuvant radiotherapy for low-grade tumors less than 5 centimeters. Anything else should mandate adjuvant radiotherapy.
I know it's tricky, and that's why I put this. I put this case. It looks very simple, that small lesion, but this case has lots of learning from
yes,
diagnosis to imaging and adjuvants. And
so margins-wise, all perfect, but still, I believe that if we add adjuvant radiotherapy, there can be improvement in local control.
Sujit?
The indications are definitely there, being a high-grade pleomorphic sarcoma for radiation. Although the margins are clear, we should offer, as an MDT, I would also support offering radiotherapy as an post-op treatment. coming to adjuvant chemo.
No, let's discuss only radiotherapy first,
So-
because chemo is a easy answer in this case, but radiotherapy is something which is really debatable, and we are planning to do a trial on this actually in TMH.
This is
What's your opinion?
this is not deep. This is not more than 5 centimeter, but the biology is definitely high grade. So I think we should discuss for post-op.
High grade, 40-year-old, yes, sir.
Adjuvant RT?
Adjuvant RT.
Okay. But what will be the advantage of adding adjuvant RT in a 2 centimeter lesion which is excised with the 2 centimeter margins? Really wide, a superficial tumor, never close to any vital structure, will definitely have some treatment-related morbidity.
I agree, sir. That's why I specifically mentioned that probably there won't be any improvement in survival, but improvement in local control.
Okay, so it raises the next question that whether RT really improves survival in soft tissue
doesn't.
sarcomas. It
No, it
doesn't.
doesn't.
Even though when we look at big, huge tumors, and this is like just couple of centimeters, and we also know that first and second recurrences in soft tissue sarcomas doesn't lead to worse survival if they are treated adequately.
No,
So-
there is one issue here. Suppose we are advising observation. This is a very clinically examinable area. There is guidelines saying that if the area can be observed closely, and if suppose there is a recurrence, the resurgery will not cause morbidity. They can be followed. But yes, I think the options should be given, and then both pros and cons should be discussed.
What's your opinion, sir?
Thank you, sir. Sir, as Sujit, Dr. Sujit has told, it is in the gluteal region.
If you can speak in the mic, please.
It is in the gluteal region. It is the only high-risk features are it is high-grade pleomorphic sarcoma. Apart from that, there is no high-risk feature. RT is controversial based on the site of the disease and based on the data. RT doesn't improve the overall survival, it only controls the local control, so it can be observed also.
Okay.
Sir.
So I will start from you, and now we'll try to address the second question. Adjuvant chemotherapy.
Can I ask a question?
Yes, sir,
here?
please.
Somebody from the panel mentioned the age. So you have the size, you have the grade. Does age come into the decision making?
To be very honest, it doesn't.
Doesn't.
But yes, if we are looking at a pediatric patient who is
No,
like,
we are talking of adults.
yeah, no.
Adults.
Because you asked age.
Yeah.
That's the reason I went to that.
No,
That's why I
somebody
said that
mentioned in the decision making, he's a young male and he's a pleomorphic. Pleomorphic agreed.
Correct.
But does age come into the decision making?
if you are looking at anybody above 15 years, it doesn't. But yes, there can be, because you asked specifically age, so I would like to highlight here that if you have a pediatric patient, then we need to be really careful. If this would have been a pediatric patient, everybody would avoid radiotherapy, even if with a slight larger tumor as well, because we know that the arrest of the growth skeletally can be big issue in pediatric patients, or otherwise we can have option of brachytherapy, which we'll discuss. Yes, so let's quickly go to the second. Indu madam, I'm sorry, I was not able to see you here. So may I request your opinion on role of adjuvant radiotherapy in this patient?
Good morning, everyone. And I think it's a very interesting session which is going on. So it's definitely a controversial situation to address, but because if we see the size of the tumor and the location of the tumor, I think as per guidelines, because it is high grade, it warrants radiation, but as Sayan also said that it doesn't lead to improve in survival. Local control rate definitely is better with radiation. And in this particular location, I don't see too much morbidity of adding radiation because there is no critical structure close by. Like sometimes we have to, we always have to take into account those parameters also. Say suppose bladder is close by or rectum is close by or any other relevant structure, then we have to be very careful. So I think we'll have to explain the situation to the patient, explain them that
Madam, we can't hear you.
So
Yeah.
we know that survival is not going to, so this has to be explained to the patient. And if they're willing and ready for close observation, then we can keep them under observation.
Okay.
But radiation has to be discussed with the patient.
Okay. So I'll start from the other side and we'll try to address the second question quickly. We have interesting 2 more cases which I want to address. Role of adjuvant chemotherapy, yes, no?
Yes, sir.
Yes. Okay. Devamalya, any inputs on chemotherapy? I know it's not your primary field, but you work
Sir, I have no idea about the chemotherapy, but I just want to say, do you think the diagnosis is correct? Because pleomorphic, high-grade pleomorphic sarcoma in a subcutaneous plane and 2 centimeter is not fitting with the diagnosis. The same looking tumor, one new entity has now mentioned in the WHO. Professor Bharatraki, I reported the 2-3 cases there in TMH. That is a superficial CD34 positive fibroblastic tumor, which is the look like a pleomorphic sarcoma basically, but it is not sarcoma. Because usually we used to get the pleomorphic sarcoma in the deep tissue, in the muscle and the deep fascial plane. In subcutaneous location, I don't think any of us.
This case was diagnosed about a couple of years back by TMH team, so I can't really comment on that. But that was the report. If there is any further classifications, I'm not aware.
One should take in mind that the superficial CD34 positive fibroblastic tumor, which is a low grade tumor basically, to rule out. But I have no idea about the chemo.
What's your take?
Again, looking at the biology, the option should be discussed.
No, you will advise, you will not advise. Adjuvant chemotherapy in a lesion which is a couple of centimeters excise widely.
Yeah. Again, the benefit is minimal.
Benefit is minimal, so you will not advise. Dr. Jadhav?
I will not advise chemotherapy for this patient.
Sujit?
I have started to use the circulator nowadays, and I will discuss. I will not be the person who will decide no. I will be definitely discussing that there is an option, and I will be going also with the circulator to see what is the percentage of chances that there can be mortality in 10 years and take a call on that.
So can you elaborate here about circulator? What exactly is circulator and how it works?
So circulator has been developed based on prognostic factors on different trials basically by the MSKCC group, and it involves different parameters: the age, the size, the histology, the site of the disease, and I think the local recurrence or not. So basically there has been a validating study on the ERTC 62931 where they divided 3 prognostic groups. One group was having more than 66% chances of survival. The second group was 50 to 65% survival at 10 years. And the third group was less than 50% survival. So they found that when they reanalyzed the EORTC study, actually the EORTC 62931 did not find benefit of chemotherapy over observation after surgery. But when they reanalyzed the study, they found that the patients who had more than 50% chances of mortality, in that group, they found around 50% less risk of distal metastasis and death in that group of patients. So the basic, the high risk factors are there: high grade, extremity tumors, and size. But still, when they use these criteria, they found that the patients who has more than 50% of mortality, they benefited with use of adjuvant chemotherapy. So as part of our MDT discussion with my Dr. Vishnu, who is our orthopedic oncologist, we have decided prospectively to use the circulator nomogram for all our patients. And in such situation, we are able to filter out some patients who may have more toxicity of treatment rather than benefit. So,
so circulator is becoming popular these days. There are a couple of validation studies, but there are a couple of studies which speak against it as well. So it has not become standard of care, but we need more study to validate it. And also a lot of people are questioning that it was studied in Caucasian population, how it fares in Asian population, because the rate at which toxicity happens in our patient is completely different. So, we really need to look at it, but yes, this is one of the options. But if you put it in circulator, it will definitely have much better survival. So, yeah.
It has a few limitations, sir. One, it only takes into account common histologies. Second, Harrell-C index, which demonstrates the discriminatory ability of circulator. It labels it as 0.7 as good, 0.8 as strong, and 1 is perfect.
Yes.
So overall, it crossed 0.7, 0.72. But if you look into the subset analysis for stage 3, it is less than 0.7. It's 0.67, and also it predicts better for the age less than 50 years. So we need to keep it in mind.
Also, as Devmalla was telling us that how the classifications are being, further classified, the studies onto which circulator was based, now the entire histopathology, now we are seeing that they are being further subdivided into various groups. So again, in rare tumors, we have these issues. So I think adjuvant chemotherapy has a very, very minimal role in this patient. Maybe we can avoid that. So coming back to doing only wider surgeries and avoiding radiotherapy, so I would like to highlight here the Japanese are the pioneers in this, and they have actually avoided radiation to non-intervened surgically treated patients with really wide margins, treated at sarcoma centers, and their local recurrence rates are no different than the patients who had radiotherapy. But it was a very select group of patients where sizes were about 5 centimeters or less. So yes, there is an option where, and we have literature, if we excise really wide and if we have small tumors, we can avoid radiotherapy. So I'll just skip this. This is again, the Japanese group has given the Kawaguchi system of margins, where actually the distance is the quantity, but they look at the qualitative margins. So if you have deeper fascias, you have thick fascias, they become a wider margin, and hence they did that. So quickly moving on to the next case, 19-year-old male student. He presented to us, actually I added these few slides in detail. Yes, sir, please.
Sorry to butt in between. So what was the final decision for that patient? Small lesion, 2
Small
centimeters?
lesion, if you can excise it really wide, we can avoid radiotherapy. But
And
obviously, we need to discuss with patient, and we need to update patient that when it is excised really wide, the chances of local recurrence are less.
Yes.
But having said that, we are trying to avoid the toxicity, howsoever it may be for radiotherapy. You need to be very vigilant on the follow-up and do that. Chemotherapy, I really don't think so, that tumors which are very small, which are excised widely, they really get benefited with chemotherapy.
Yeah, the actuarial overall survival in a very, very small tumor which has a wide excision, I think chemo should not be given.
Yes, this is what actually
Yeah.
we had consensus. And even when we look at the SMAC analysis and SMAC2 analysis, there also it showed that the patients who got maximum benefit in survival were the patients who were deep-seated, large tumors, more than 5 centimeters, high grades, and there was a subgroup which had closer margins. So that subgroup had the maximum benefit in terms of DFS and the OS. So this case completely, shift is on the other side, where we can really avoid any sort of adjuvant therapy. Anyways, so large tumor, these slides were actually put, I thought we'll have some students to how to have the right examination findings. So in nutshell, it is a big soft tissue sarcoma of the proximal thigh in a 19-year-old student. And this was the X-ray. Just one quick question here. Do you really ask for X-rays to your patients who present with soft tissue sarcomas, and reason? Sujit? Or is it just a waste of an investigation?
No, in case of before pre-surgery evaluation, I think X-rays are definitely needed. One thing is for seeing whether there is any cortical erosion. For limb salvage planning, they need the X-ray, and for follow-up also we might need. So definitely we get an X-ray in spite of having an MRI.
It's a very simple investigation, and we should do it. A lot of people ask whether we should do or not. Many times they can help us to clinch the diagnosis, like for example, synovial sarcomas can get calcified, and so you can really diagnose them. They can help us to differentiate between myositis. Fibromatosis may also, look very dark, look slightly different. There's a very important finding: a long-standing lesion like fibromatosis may have indentation onto the bones, which may not be very apparent on MRI, but on X-ray it will look very nice. So these are a few important things which we should remember. And as we all know that MRI is the investigation of choice. So this is the axial cuts. Maybe anybody can speak about it, or anyways, I'll go through it. So there's a heterogeneous large soft tissue lesion which is in the anterior compartment. You have So you have vessels which are abutting onto, which are stretched completely. Another very tricky point here is if you go posteriorly, then you have this lesion extending along the ilios vas at the attachment near the lesser trochanter. So, surgically it's a very technical point, and it might raise some debate whether it is R0 is possible there or not. Few of the coronal cuts which you have, again showing large lesion. So we did biopsy. It came as synovial sarcoma, and these were the slides. So Dr. Devmalla, if you could describe the slides, what can be the differentials here, and how do we diagnose this as synovial? Mike.
The two images are there, and one images show only the monophasic, the monomorphic population of the spindle cells, and another show the both component. There is a spindle cells as well as some epithelial loop glands. So basically, when we get this classic biphasic appearance, it is a very easy to diagnose synovial sarcoma. It is actually can be a monophasic, can be biphasic. So getting the glands and the spindle cells is an easy diagnosis. Then we just confirm it by doing some IHC. Synovial sarcoma is a sarcoma which shows the limited epithelial marker positivity like CK and EMA, and the positivity for the other markers like your calponins and CD99. One recently used, the most useful markers is the TLE1, which confirm the diagnosis, which is almost 98% specific for the diagnosis. But when we get the monophasic synovial sarcoma, when it is just only spindle cells, then it is a little bit difficult, because there is a lots of differential starting from the malignant peripheral nerve sheath tumor, like from the spindle cell rhabdomyoid sarcoma, the leiomyosarcoma sarcoma, this all come in the differentials. And we have to, this is basically pathology discussions, I don't want to bore you. There are some pattern basically, the hemangiopericytomatous pattern, which help to make an idea it can be synovial, and of course the same panel of eyes is helpful for diagnosis it. But in difficult cases, when the morphology and immunohistochemistry is not matching with each other, then these cases we need the confirmations by the molecular translocations. Synovial sarcoma show the classical molecular signature when there is a 18 chromosomes, there is a gene, SYT, and in the X chromosome there is the 3 partner genes, SXX1, 2, and 4. And with any of these partners, this translocation can happen. And these are the fish, interface fish, which we can done in the paraffin blocks basically. And these are the dual color break apart probes, which shows nicely the two separate signals. One is a red and one is a green signals there, which indicate that there is a break in the SYT gene loci in the 18 chromosomes. So these are the confirmations. We can also do the RT-PCR for the synovial sarcoma, for this confirmation, this translocation. But FISH is little bit better, and in our institution, Narayana also, we have initiated the FISH techniques for the confirmation of these translocations.
Thank you. Thank you, Devmalla. So just one question here, that how often you need to do molecular testing in soft tissue sarcomas?
For the synovial sarcoma, I'm just telling you, it is not necessary every case we do the confirmation of these translocations, though this partner of the translocation has some little bit low in prognosis. The SYT SSX1 has the higher chance of metastasis than SYT SSX2, but
I'm just asking you in terms of getting the right diagnosis.
Sir, please.
In terms of getting the correct diagnosis, how often you need to use the molecular testing? This is what.
In recent classifications, there are the lots of sarcomas, they are the molecularly defined. Like the small round cell tumors, which only one group as the Ewing sarcoma and others we categorized as the Ewing's family of tumor.
Correct.
Because their immunohistochemistry is not matching with the classical Ewing sarcoma. So these groups now reclassified in the recent WHO classifications, like the SIK-DUC4 mutant tumor, the BCOR mutant tumor. So for these tumors which are unclassified still now, for their molecularly defined classification has come out, they required for this diagnosis. But for the routinely almost 90% cases, it is only the morphology and immunohistochemistry is good enough for diagnosis. It is required only the 10% cases where the morphology and ISC is not matching with each other, then for the reconfirmation.
Very well put, very well put. Thank you so much. Okay, so we move ahead. I think staging, we discussed it a bit. We'll skip this. I know there are various modalities for staging. Usually we do the first one as we discussed, and obviously if you have multiple lesions, you can go for PET CT as well, which can be single stage investigation. So let's come to the main part again. We are sitting in MDT. This is a big lesion which is pretty close to neurovascular bundle. It is close to the bone near the attachment of the iliopsoas. What will be your thought in terms of whether you want to give chemotherapy first, whether you want to start with surgery, or you want to combine chemotherapy and radiotherapy to, try to shrink it? What are your thoughts? I'll start with you.
So I'll discuss first with surgical oncologist. If he's expecting positive margins, then I would consider for neoadjuvant therapy. At our center, we have never used neoadjuvant CTRT. So we'll be using sequential therapy, but not a concurrent therapy. Okay. So if it is a sequential, we'll first proceed with neoadjuvant chemo, decrease the size of the tumor, then plan for preoperative RT, followed by surgical.
Okay. Sujit?
So the lesion size has been 20 by 15, as you mentioned. So definitely this patient needs both all three modalities of treatment, and the lesion is going posteriorly. It is very big, and I think definitely in the MDT, the surgical feasibility should be discussed first. If it is operable, it should be taken, but going by the size, it might be a difficult and morbid surgery. So, and here, when the surgery is done, post-operative fields for radiation also would be very high. So I would rather consider for NECTRT in this situation, and followed by surgery would be my preferred option. Although it's synovial sarcoma, they are chemosensitive tumors, but because of the size, I would prefer to have an NSCTRT approach if it is feasible from the radiation oncologist.
Yeah, so as other panelists have also mentioned that it's a large tumor, most probably we are expecting a morbid surgery. So this patient would require all the three modalities of treatment for his.
Yes.
The only question is how do we sequence the modalities?
Exactly.
How
do we sequence, and is there any concern with that sequence?
Yeah. So if we see, if we are going to use all the three modalities, especially with radiation, the opinion is more in favor of giving the radiation before surgery. And in this case more so because it's going to be a large excision, and the possibility of post-op RT fields are like, the fields will be very big, which will be very morbid. So obviously radiation would be given before surgery as neoadjuvant radiation. We would also like to have a modality that will give us a good amount of response in this setting, because it's a large tumor. If we get a good amount of response, the surgery would be a tad bit easier in this scenario. I would go for neoadjuvant CTRT, as sir has also mentioned, because in that study, which was I think published in 2015, they did achieve good amount of response rates to the order of about 63% response rates with combining of chemotherapy with radiation. At our center, we don't do it. But if the patient is in a center where the expertise are available, neoadjuvant CTRT would be my choice also.
Challenging, isn't it?
Yeah, no. Yeah, again. So My only concern would be it's kind of approximates the neurovascular bundle. So that is where probably an R class resection is preempted. So definitely requires neoadjuvant therapy. So looking at the options,
We are good surgeons, we'll take it out, don't worry. We'll
So-
get you R0.
if you can say that you can get an R0, fine, go ahead. But otherwise, I would offer definitely pre-op radiotherapy. But as my co-panelists mentioned, we usually do not prefer pre-op radiotherapy. We usually
I
prefer
was
post-op.
expecting that from
Yeah.
you, and we will maybe we'll have a discussion from the everybody also, the how comfortable they are to combine NACT RT in their patients, and are there any particular indications for that?
So
we'll
again,
come there.
I would rather sequence with a pre-op RT followed by chemo followed by surgery.
Okay.
Yes, sir. So as the tumor is very large, so the surgery will be a morbid surgery, and in fact, due to the bulk of the tumor, the patient will need all the three modalities. So as the synovial sarcoma is a chemosensitive tumor, so I will prefer for giving the chemotherapy first, followed by RT, pre-op RT, because in the post-op RT, the dose of the RT field will be very high, and the post-op wound healing will be delayed by the RT. So and post-op wound healing will delay the RT. So I will prefer pre-op RT followed by surgery. Then,
Dr. Indu, what's your take on this case? You would advise preoperative radiotherapy. Would you ask me to operate first and then give post-op, or you're going to combine NACT RT?
I think in this particular situation, the expertise of the surgeon plays a very, very crucial role. So if my surgeon is comfortable and confident in taking out the tumor in first go and without causing any morbidities, we have to remember this is a 19-year-old boy, and limb preservation is a very, very important component. So, so we don't have to give any morbidities to this boy. So if my surgeon is comfortable with pre-operative radiation, followed by surgery, then I think that is the preferred modality, because for a 20 centimeter tumor and close to the neurovascular bundle, when we give radiation, then the funnest fields are much smaller. Number two, the risk of wound complication is 37% less, and the chances of neurovascular morbidity, I think, also is much lesser. And the field of radiation and the chances of lymph edema, post-operative edema is also less. So the dose of radiation is also less, and the tumor is much better visible, because when we give radiation post-operatively, we have to take into account all the soft tissue extension, or the edema also has to be taken into account. So if my surgeon is comfortable, then I would preferably, definitely pre-op RT is a better modality.
Thank you.
There
So,
is no confusion on that.
yeah. So, we also, how confusing it is. So in TMH, we have tried everything. We have tried NACT, we have tried NART, we have tried surgery, everything. So I'll just summarize it for you, what has been our experience, though we have not published it in length. If we can excise even these large tumors, we do go for surgery first if we can achieve R0 if we feel. We had some discussion where we had some point that, surgery will be more morbid now. To be honest, the margins of resections remains the same, whether we shrink the tumor or not. So the muscles where the tumor is there, that muscle anyways will go. So it really doesn't change the morbidity. It is the feasibility of the surgery and the rate of achieving R0, which is changed with the help of neoadjuvant therapies. Any patient where we feel that it will require a vascular resection because it is very close, so the abutment is more than 180 degrees for the vessels, or it's extremely close to the nerves, we tend to give preoperative radiotherapy in these patients. Our standard modality will be to operate, get R0, and then give post-operative radiotherapy. O'Sullivan's trial, the Canadian group from Toronto, clearly showed that we have this discussion with Jay Wonder multiple times. They only exclusively practice preoperative radiotherapy. There's not even a single patient where they will operate first and then give. And that trial, which has now 2 papers have come up on the same group of patients with 15 years of follow-up now with the recent paper, clearly showed that the rate of wound complications post-surgery is exactly double. So it's about 17% they had when they had operated first, and it became 34% if they have given pre-operative radiotherapy. So we definitely know that the rate of wound complication is double when we give pre-operative radiotherapy. It's more so in the proximal sites. So let's, for example, this case where it is thigh, it going to have wound necrosis, it going to have lymphedema, it going to have long prolonged drains and stuff like that. So what they did it after their first paper, they started doing flaps electively for each and every patient. So if you are looking at that, then you are adding another surgery, or you are increasing the time of the surgery if you want to avoid those complications. So now for every patient they will operate. If they have given pre-operative radiotherapy, then they will do a primary flap, because they know that almost 1/3 of the patients will have these issues. Second problem with radiotherapy wounds, as you all know, that they are very, very difficult to heal. So that's why they started doing primarily. Second point is that, as we all discussed, that the area of radiation will increase with post-operative radiotherapy. So, you know, we want to avoid. So this is how we do it. Coming to neoadjuvant chemotherapy, we definitely practice that, and there are multiple reasons for it. Number one, we have a waiting list, and we don't want our patients to have increase in the size of the disease. Number two, specifically, cases like synovial sarcoma, which are these histopathologies which are more chemosensitive, we tend to give them neoadjuvant chemotherapy more rather than neoadjuvant radiotherapy, because we want to avoid the complications as well. We don't want them to grow also, and they do respond as well with the chemotherapy. Third is combining both. To be very honest, is pretty toxic. We have had very difficult situations at times. So, and looking at the papers, there are 2-3 trials which have shown good response. But what we realized is distal the tumor, like from, you know, below the elbow or below the knee, where the toxicities with the radiation will be less. So hemopathic toxicity get exaggerated if you have the proximal tumors like near the pelvis or the thigh. So in the peripheral lesion, if we feel that there's a tumor which really requires, which is borderline resectable, or it might go for amputation, and if it is peripheral, to get better response, we have combined them. And obviously, we are not discussing round cell tumors here, because they are a completely different entity. So this is in a nutshell how we do, and this is what we did for this patient as well. Neoadjuvant, we excised it. Yes, sir.
Just for my knowledge, NACT-RT, how do you give it? What are the drugs and what is the schedule? Just a short, crisp.
Sujit, you would like to highlight that?
So,
because we generally don't practice NACT-RT in sarcoma.
So it's the same protocol. We start with ifosfamide doxorubicin as first cycle. With the second cycle, the radiation is added, and it's completed. So that once the radiation is over, after 4 to 6 weeks, the surgeon is taking up. So in that regard, I wanted to highlight, there was a study last year published in Lancet, where the study was in adolescent and young patients, where NACT-RT plus pazopanib was given, and the outcome was in terms of pathological CR rates. So that was a feasible study, and nowadays we don't, we have patients who come, especially pelvic osteosarcomas and pelvic soft tissue sarcomas, which are not operable or operable with a heavy morbidity, who come for direct RT because proton therapy is there. They come for proton therapy, and we have had patients who have come with large pelvic sarcomas, not operable or operable with, maybe they need heavy hemipelvectomy and all. So in those patients, we have used, for last 4 patients, I have used pazopanib alone as a radiosensitizer. And at 1 month and 3 months, the radiological response rates have been very good. We had a concern whether they will have systemic toxicity, but they all tolerated it very well without much skin toxicity also. So I think instead of NACT-RT, suppose there is a need for neoadjuvant RT, giving pasopanib 600 milligram as a daily dose concurrent with RT will be a feasible thing in our patient. At 5 patients we have experienced, even with not with proton, even with tomotherapy, we have seen the skin toxicity has been only grade 2. So I think that would be a way forward where we can use it. And giving iphosphate adriamycin, definitely adriamycin also have radio recall reaction, so it might be difficult for our patients.
So specifically in this case, since this is a chemosensitive tumor, couldn't we just get away with NACT followed by surgery and then post-op RT? Would that sequence?
Absolutely, that's what I did. We gave 3 cycles of IFOS Adria, and we operated this patient. We achieved R0, and that was negative margin, and then we discussed for completing the remaining 3 more cycles of chemotherapy, and obviously as we have discussed that RT is must in these patients, and these are the group of patients, as we have been discussing from last half an hour, who gets maximally benefited with the all 3 modalities. So just to brush up, that definitely.
Ashish sir,
yeah.
One question.
Please.
I would like to ask Sudhit sir.
Please.
That Sudhit sir told that sir had practiced few cases of NACT-RT, means giving chemotherapy with IFOS Adria, and then starting.
I was just mentioning the protocol. I just have given pasopanib concurrent with the radiation. Not chemo. Because definitely in pelvic side, giving chemo along with radiation is not going to be feasible.
So I was asking that only.
It becomes very toxic, and especially when we look at combining the toxic therapies, the tolerability in Caucasian population is much higher. Our patients, we really need to be very, very careful. You just can't replicate the same results here, even for the surgery also, even for the wound healing, even for the kind of blood loss they tolerate, it differs. So as we all discussed, that radiotherapy definitely benefits in local control, and in well-selected patients up to maybe 50% improvement in the local control. We can add both pre and post. Larger tumors with closer margins will get benefited more, and we all know this, that the Rosenberg's trial was the landmark trial which we did, and I have just put another patient here where actually we used preoperative radiotherapy in this patient, specifically because the diagnosis was liposarcoma here, and we know that liposarcoma respond very well to radiotherapy, and this patient received preoperative radiotherapy. Even though the site was same, size is slightly more bigger, vessels are more closer, and you can see almost about 50% response coming only with preoperative radiotherapy, and then we operated this patient. This was the trial I was talking to you about, which is Brian O'Sullivan's landmark trial, which has now 2 follow-up papers onto it, and it tells us about what is the difference between pre-operative and post-operative therapy. Globally, the world is divided, and there's no survival advantage of either of each. It's just what suits your system that works better. Another systemic analysis was done, and it shows almost the same results. Brachytherapy, let's discuss brachytherapy. Any experience with brachytherapy, any indications and contraindications? Quickly, we have just a couple of minutes more.
Okay, so as you have mentioned, so brachytherapy, yes, a very, but again, it has to be suitably selected population. So even Dr. Laskar's paper is there with long-term results, where he has used brachytherapy as a single modality as well as brachytherapy as a boost following external beam radiotherapy with excellent local control rates. However, as you mentioned, for larger tumors, we prefer brachytherapy as a boost.
Absolutely.
For smaller tumors, brachytherapy as a single modality as adjuvant therapy is good enough.
So what we need to understand is in brachytherapy cannot replace external beam therapy because indications are different. And if a large deep-seated tumor, you can't deliver that kind of brachytherapy. Yes. Superficial tumors, yes, we can. And there's a long learning curve with expertise required,
it requires a lot of skill and expertise.
which is difficult. Let's quickly go to the chemotherapy part, and we all know that there are some chemosensitive and chemoresistant tumors, and advantages definitely more in chemosensitives. And when we have tumors like epithelioid sarcomas, sarcomas, there we need to move away from the conventional chemotherapy and look at more alternatives in terms of interferons, and now we have more targeted therapies coming up. So I think that's the way forward. So maybe Sujit, if you can highlight what will be the role of newer agents in chemo-resistant soft tissue sarcomas quickly, so that we can move further.
Yeah, so we have alveolar soft part sarcomas are very much sensitive to pasopanib, sunitinib, sorafenib also. They are also found to have response to bevacizumab and temozolomide. So in case of solitary fibrous tumors, again pasopanib is useful. In case of the inflammatory myofibroblastic tumor, they are ALK positive, and crizotinib has found to be useful. So we don't use chemotherapy upfront for these patients. And definitely in these in rare soft tissue sarcomas, it definitely makes sense to use next generation sequencing to find out whether there are any molecular markers.
Okay. So let's play some rapid fire. Your choice of adjuvant chemotherapy in conventional soft tissue sarcomas.
I plus S.
Same?
IFOS doxorubicin.
Everybody same? So no changes. So the message is clear that even though we have a lot of newer agents, but the first line remains the same. Anybody for only Adria alone without IFOS? No, I'm talking about adjuvant. Okay. Why so? Any specific advantage?
So
because I'm just asking those questions which are asked multiple times. Patients have higher toxicity, they can't tolerate. Then they require GCSF, we can't manage, and ICUs are not there. We work in periphery, so can we only go with Adria?
No, there was one ERTC trial which had avoided ifosfamide in their adjuvant, and they had inferior survival. So one of the reasons why the ERTC consensus or the pooled analysis was negative for adjuvant chemotherapy is said to be because ifosfamide is found to be having a major benefit as an adjuvant chemotherapy. So I think ifosfamide should be part of the adjuvant.
I think there is an optimal threshold for the anti-tumor efficacy. If at all we are using ifosfamide, it has to be at least 6 grams per meter square. Otherwise, there is no use.
So adding IFOS is wise. And to be very honest, if you really want to have some benefit from chemotherapy, because anyways the benefit marginal, and this is what we saw in this first generation trials where IFOS was part of only couple of trials and the responses were very low, and we had really almost flat curves overlapping with each other without any survival advantage. And then we had SMAC2 where we had newer trials added where IFOS was part of each and every trial, and we started seeing that difference of about 6% survival advantage. Again, there is a controversy there. Then in SMAC 2008, this negative trial was avoided, which was actually one of the largest trial.
But again, they have used 5 grams per meter square.
Exactly. So, what I'm just trying to highlight here is that there is the data is so sketchy that you can't really swear and say that this works and this doesn't work and how much it helps. So, but what we know that adding adjuvant chemotherapy in high-grade large tumors, it gives benefit. We need to choose our patients very carefully. If they can tolerate, then yes, we should. Last word on histopathology specific tailored chemotherapy. Do you practice? Yes, no?
No, sir.
Okay, yes, no?
No.
No, we don't practice. Actually, there is a randomized controlled trial based on the histopathology based chemotherapy, in which they have randomized patients with specific histologies which are known to be sensitive to certain chemotherapies versus the standard IFOS Adria. And this was a negative trial in which they said that histology based chemotherapy tailoring is actually inferior to the standard IFOS Adria. So
actually, the trial was stopped in between when they had the interim analysis done, and they showed that the standard chemotherapy works better. The only positive take was that myxoid liposarcoma, they did better. and trabectedin was shown that it has better effect. Apart from that, everything was just negative. So we know that chemotherapy has marginal efficacy. Additional benefits are better with addition of ifosfamide, but we need to look at toxicity and select our patients very wisely. Larger tumors, intermediate to high grade, should definitely get, and as you rightly said, that the dosage has to be correct. You just can't compromise looking at that. The patient will have toxicity. Almost every patient in mesenchymal tumors, whether it's bone sarcomas or soft tissue sarcomas, if you give the right dose, they will have some kind of toxicity, but we just need to know how to handle them better rather than giving the inferior treatment. I think we'll just end here. I have already gone past time. Maybe just a word from Sujit or anyone, that palliative settings, what do you prefer and why? Bilateral large tumor, bilateral multiple pulmonary metastasis not resectable. We need to palliate this patient. I know we can talk about radiotherapy in palliation, we can talk about surgery, but as a systemic therapy, how best you palliate them and reasons for it.
So we need to see definitely the early palliative care should be part, including pain relief and other measures should be part of the treatment plan. We should see the histology of the patient, the age of the patient, and the performance status. Here is synovial sarcoma. We have had patients of synovial sarcoma who respond beautifully with single agent doxorubicin and live long and with a good palliation. So I think histology will have a call when we decide. The second thing is, even if we are not able to do adriamycin, pazopanib can be used as a first line agent for these patients. So definitely we should consider either adriamycin single agent or pazopanib, or sometimes like as per the histology, whether it is a soft part sarcoma, we have some specific agents. So I think apart from the best supportive care measures, we can consider single agent doxorubicin or pazopanib.
Absolutely. So I used to be a very big fan of giving single agent dox, but I think last couple of years, with the ease of administration pazopanib has, and these patients can then go to their home and then I think, and that is becoming the drug of choice nowadays, and I'm sure we will have more agents coming up which will be less toxic and maybe have better palliation.
And now we have generic pazopanib, so the cost also is not an issue.
Thank you so much everyone for helping me out to put these messages forward, and thanks to the organizing team to give all of us this chance to discuss these rare tumors. Thank you.
Thank you so much.
Yeah, please.